think he was appointed as a senator in the Canadian Parliament. Dr. Fahd Abdul Jabbar, when I finished training and came back to Saudi Arabia, was the director at the hospital. And he really was instrumental in starting or in promoting cardiac surgery at the hospital, and really responded to all my needs to expand the program at the hospital, which was at the time very, very limited to the level that we were able to build a full heart institute or heart center. Dr. Carlos Duran was the first chairman of the Department of Cardiovascular Diseases at the hospital, and that included the adult cardiology, pediatric cardiology, cardiac surgery under the same department. And he really, he saw how hard I work. But if you remember from what Marcello just presented, it's never really how hard you work. You know, if you don't publish, people will never recognize you or give you credit. And he taught me that fact and helped me in publishing and in establishing a research and academic career. Lastly, I owe all this to my family, who really gave me unconditioned support day and night, recognizing the many hours and days and that I'm away from home. Thank you, family. Now to the beef. Islamophobia, an ugly term, but unfortunately it has been used and introduced, and it refers to the indiscriminate negative attitude or emotions that are directed against Islam and Muslims. We all remember the attacks in New York, the 9/11 attacks, and this really kind of changed the whole concept of many aspects of our lives in the world. And at that time, there was organized mobilization against Islam and Muslims, which really surged after those attacks and gave rise to what became transitional anti-Islamic movement. And this really went on for many times, and despite the fact that a very few number of Muslim American terrorists and suspects that were detained at the time since 9/11, which is just a fraction of the thousands of acts of violence that occur in the United States each year, the stigmata remained associated with the Islam and Muslims. A lot of chaotic actions occurred in many parts of the world, mostly by outcast groups that led to more defamation of Islam. And all of us remember the restrictions that were imposed on us traveling, particularly air travel, where actually one would think that that's the way you should be boarding an airplane. This even pushed many to leave their homes and seek refuge, taking paramount risks. This picture, I think, stirred emotions all over the world of a Syrian boy that was killed with his family trying to cross the sea to a safer place. But I can assure you, Islam is not that. There is always a very thin line between what is true and what's being said, and it sometimes takes quite an effort to navigate your way through facts and to know what's right and what's wrong. And this is really great Muhammad Ali mentioned. It is not the mountain that wears you out, it's the pebbles in your shoes. Little things can make a big difference and lead to a lot of misunderstanding. And simply, it's what we all know as what one bad apple ruins the bunch. Islam, as a holistic belief system, points optimum emphasis on the mental, physical, emotional, and spiritual well-being of individuals and societies. And there are certain teachings that we Muslims recognize in our religion. The teachings of Islam stress the importance and respect of learning, forbade destruction, encouraged cleanliness and personal hygiene, emphasized respect of authority and discipline, and also emphasized tolerance to other religions. With all these teachings, the Islamic Empire at one time extended from the Atlantic Ocean on the west and to the borders of China on the east. Medicine was one of the many fields that Muslim scientists explored, and here is a list of many scientists and physicians that contributed quite a lot to medicine all throughout history. Some of the names, Al-Razi, or Razis as known in English, who was an internist. Al-Zahrawi was a surgeon, and Ibn Sina, or Avicenna, a physician and a philosopher. Ibn Rushd, a physician, philosopher, and an expert in jurisprudence. Ibn Nafis, which was named as Avicenna II, a pioneer in physiology. Ibn al-Haytham, an ophthalmologist. Yaqub al-Kindi, a philosopher, mathematician, and a physician. And Jabir ibn Hayyan, who's actually considered as the father of algebra, and he was also a chemist. Just go through some of the contributions of a few surgeons. We know Al-Zahrawi, which is known as the father of surgery, born 1963, died 10/1/13. The famous book called Al-Tasrif, or The Method of Medicine, was translated into Latin 5 times by the Europeans. Al-Zahrawi operations included a cesarean section, and he was the very first to use silk threads for stitching wounds. Ibn Sina, or Abu Ali Hussein Ibn Sina, was deserved the title a sheikh or a rayis, which means the chief master. And actually, he was recognized, and this is a stamp by just recognizing him from Pakistan. The very famous book that was written by him is called Al-Qanun fi al-Tibb, which is named like the Bible of medicine, and was very comprehensive, and actually described by William Osler as being the medical Bible for longer periods than any other work. William Harvey in 1628 described the pulmonary circulation, and many hailed him as the one who really described that. But in fact, Ibn Nafis was the one who described the circulation, including the pulmonary circulation, way before William Harvey was born. And actually, this fact was a controversial issue, and it was the subject of many editorials, but I think the issue is settled, and now it's well recognized that Ibn Nafis was the first to describe the pulmonary circulation. He said that the heart has only 2 ventricles, and explained also the coronary circulation. Ibn Nafis was a teacher. He wrote 10 books. He took charge of Al-Nasiri Hospital in Cairo, and he trained physicians. And he was the very first one to issue a medical certificate for his trainees, indicating that those trainees have been well trained and ready to function on their own, most like a certificate. Ibn al-Tabari, who's a philosopher, and a physician in 970 produced what we call the ethics, medical ethics in Islam. He described that the physician, the personal characteristics of the physician should be, that the physician should be modest, should be virtuous, should be merciful, should be unaddicted to liquor, and should be dignified and forgiving and never seek revenge. These are the personal characteristics of the physician. Should be a friendly and a peacemaker. Then he described the obligations of the physician towards the patients. He should avoid predicting if a patient will live or die. He should be temper controlled and treat all, no exception. Obligation of the physician towards community. The physician should speak no evil of reputable men of the community or be critical of anyone's religious belief. Obligation of the physicians towards his colleagues. Should speak well and not honor himself by shaming others. Physician obligations towards his assistants. If his subordinate does wrong, the physician should not rebuke him in front of others, but privately and cordially. This is a verse in our book, the Quran, that refers to the fact that if somebody fears not having money to treat or have children because of that, it just says, and kill not your children for fear of poverty. We shall provide for them as well as for you. Surely the killing of them is a great sin. The recent pandemic, the Corona-19 virus pandemic, affected the whole world in an unprecedented way. We all lived through it. Over 535 million people got infected with the virus, and over 6 million died. We believe we are almost over it, but what were the most effective measures to control the disease? Hand washing, face covering, social distancing, and travel restrictions. All practices that are promoted by Islam. More than 1400 years ago, Prophet Muhammad, peace be upon him, taught his followers various forms of hygiene practices that are still applicable in the 21st century. He instructed his followers to cover faces when sneezing and to wash hands all the time. A very well-known proverb, an ounce of prevention is worth a pound of cure. A little prevention before a crisis occurs is preferable to a lot of fixing up afterwards. And interestingly, this proverb was promoted by Benjamin Franklin, who said this phrase in 1736 in order to remind the citizens of Philadelphia to remain vigilant about fire awareness and prevention. However, this proverb is used widely in Arabic literature to the extent that some believe that it was a saying by the Prophet Muhammad. It mostly refers to health issues, and I think that's the way it's known in most parts of the world now. In the year 638, a plague that was called the Plague of Amwas was a bubonic plague or Black Death epidemic that affected the Islamic Syria. That's between 638 and 639. At the time, Umar ibn al-Khattab was the caliph ruling the Muslim world, intended to prevent the illness and death of his top commander, Abu Ubaidah. So he tried to bring him out of the infected zone to Medina. But the Abu Ubaidah refused to do this and abandon his men who were in the area of the plague. So Omar consulted the Muslim scholars, and the verdict, or one group argued against entering or fleeing the plague affected area. Exactly what we did during the pandemic travel restrictions. This is Dr. Yashinori Oshumi. He's a Japanese biologist, Nobel Prize winner in physiology and medicine in 2016, and he's specialized in autophagy. Autophagy is the natural conserved degradation of the cell that removes unnecessary or dysfunctional components through a lysosome-dependent mechanism. Basically, a process that cells use to destroy and recycle cellular components. The term was coined by a Belgian biochemist, Christian de Dove, in 1963, who was also a Nobel Prize winner in medicine in 1974. So basically what happens that sequestered and damaged molecules are gathered up, and through the process with the lysosome, the destruction of the cargo inside the cell occurs. And this is actually a body's way of cleaning the house. It happens during starvation, calorie restrictions, and fasting. If this does not take place, damaged cells and components can accumulate dangerously. Autophagy is also one way the body uses to neutralize cancer cells and degrade cells infected by bacteria and viruses. This is inclusively alike the divine decree of fasting in Islam that was revealed more than 1400 years ago. Fasting activates autophagy, which helps slow down the aging process and has a positive impact on cell renewal. The question is, does the Muslim way of fasting, as in Ramadan, with no water or food from dawn to dusk, really have any health benefits? And indeed it does. It has been proven that intermittent fasting has many health benefits with whatever way you do it, whether it's alternate day fasting or 5 to 2 day fasting or daily time restricted fasting. It was shown that it has effects and reduces the effects on Alzheimer's disease, arthritis, asthma, multiple sclerosis, and stroke. A Muslim would obtain, therefore, benefits of both spiritual and physical health if he practices fasting with the right intention and purpose. Health benefits which follow are a form of preventive reward granted from Allah. And interestingly, the act of fasting is practiced by many other religions and philosophies. And the reason for that is generally spiritual. These include Buddhism, Christianity, Judaism, Taoism, Jainism, and Hinduism. Fasting can last for just few hours or even a few weeks, usually with the practitioners eating at night. In 1804, King Al-Mansur Kawaloon built a hospital in Cairo, which exists till today, called Kawaloon Complex, which included a mosque, a hospital, a school or madrasa, and his mausoleum. The hospital had different sections for various diseases. That was for the first time. And the infectious diseases were assigned a special ward. Music therapy was also used as a line for treating psychiatric patients. They also had separate wards for female and male patients. The hospital served more than 4,000 patients daily. And the interesting thing that on discharge, the patient received 5 gold coins to support himself until he can return to work. Social support. There were many other hospitals that had the same practices, and actually one of them was built here in Marrakesh in 1190. Dental hygiene. Prophet Muhammad, peace be upon him, recommended its use. He is quoted in various hadith extolling the virtues of miswak, which is taken from a plant called Salvadora perisca, where if not for the fear of overburdening my ummah or followers, I would have ordered them to brush their teeth with siwak prior to every prayer. Marriage in Islam, Prophet said, choose the best for your sperm and marry a compatible woman. Prevention, social, medical, genetically transmitted diseases. And actually in Saudi Arabia nowadays, premature genetic screening and genetic counseling is compulsory. But this does not have a full awareness, and this actually article looked at the awareness of premarital screening and genetic counseling among Saudis and the association with social demographic factors, a national study. And it seemed that more awareness needs to be done about that particular issue. At the hospital, King Faisal Specialist Hospital, we established what we call the Congenital Heart Defects Registry to capture most of the referrals of patients with congenital heart disease, making it the closest to a national registry. The registry functions as a data warehouse, studying the incidence, prevalence, possible underlying factors contributing to congenital heart disease in the kingdom, in addition to common extracardiac medical problems associated with congenital heart disease. Interestingly, 57.4% of patients with congenital heart disease had consanguineous marriages. As you know, consanguineous marriage is common in our area, and we actually published this as early as 1999, demonstrating that first cousin matings and congenital heart disease in Saudi Arabia is a risk factor for congenital heart disease. There were a couple more publications about the same subject, but all proved that it's better not to have a consanguineous marriage. Lastly, if we look at obesity, is a global epidemic with increasing obesity prevalence for most countries since the 1980s. As you can see here, even death from obesity in 2019, that the countries with higher obesity rates have higher death rates. Obesity contributed directly to increased incidence of cardiovascular risk factors, including dyslipidemia, type 2 diabetes, hypertension, and sleep disorders. And as you can see here, almost every system in the body can be affected by obesity. Fundamental strategy of the US government set more than 30 years ago points to the fact that prevention of premature atherosclerotic disease be adopted as long-term national policy for the United States. To implement this strategy, adequate resources of money and manpower should be committed to accomplish the following: changes in diet, prevent or control hyperlipidemia, obesity, hypertension, and diabetes, elimination of cigarette smoking, and pharmacology control of elevated blood pressure. In Saudi Arabia, the age-adjusted prevalence of obesity was 35.5%, with overall prevalence of 35.6%, while severe or gross obesity was 3.2%. Females are significantly more obese with prevalence of 44% than males. Unfortunately, there are no data to justify decreasing trend in obesity in Saudi Arabia. However, there are many new regulations that were recently introduced that may contribute to in the future to reducing obesity. Some of the new changes that we have witnessed in Saudi Arabia include keystone changes, allowing female fitness centers to open since 2017. Currently, more fitness centers for both genders are opening across the country. The introduction of physical activity classes in female schools. The government initiated quality of life programs as part of the Vision 2030 plan. And also allow printing meals calories in restaurants was also introduced in 2019. We know that lifestyle modifications and subsequent weight loss improve both metabolic syndrome and associated systemic inflammation and endothelial dysfunction, but this does not work all the time, and that's why there is a surge at the present time to have bariatric surgery, which has been proven to decrease, if successful, to decrease the cardiovascular risk factors. A common saying for us claimed to be from the Prophet Muhammad, but it really did not turn out to be. We are people who do not eat unless we are hungry. And when we eat, we do not eat to our full. And this is actually what would be a proper etiquette for eating in Islam. Eat and drink, but avoid excess. The son of Adam does not fill any vessel worse than his stomach. It is sufficient for the son of Adam to eat a few mouthfuls to keep him going. If he must do that, that is, fill his stomach, then let him fill 1/3 with food, 1/3 with drink, and 1/3 with air. A believer eats in one intestine when one intestine is satisfied with a little food, and the non-believer eats in 7 intestines. That means eats much. So it advises us to be preventive and avoid excessive eating and stay away from obesity. Everything will be okay in the end. If it is not okay, it's not the end. It has been a privilege and honor to have served as your president. Thank you.
Can my audiovisual helper come up? Zohar, that's going to be a tough act to follow. Sit up. Where's the changer? Okay. So this is usually the highlight of the World Society scientific meetings, the presidential address followed by the Aldo Castaneda lecture. So we are honoring the teacher of many, a pioneer, a true pioneer, Aldo Castaneda. There's a picture of the first Washington meeting of the World Society of Pediatric Congenital Heart Surgery, at which meeting the first speaker of the Aldo Castaneda lecture was Aldo Castaneda himself. And we all know we're very sad of the passing of our friend and teacher Aldo Castaneda, coincidentally a few months after the passing of Bill Norwood. And you can see this picture in Guatemala at the special meeting we organized to honor his 80th birthday with the volcano behind us. So, this is our lecturer today, our friend, Giovanni, the love of animals. There he is as a very focused and determined boy. He was born in Treviso, Italy. And you can see that everybody's doing their work, but he was keenly aware of the camera, kind of looking up a little bit to see what's going on. This is in 1983 in Australia, in Melbourne, with Roger Mee, Bill Brown. And there you can see Giovanni to the, I guess, the far right of the picture. And during that stay in Melbourne, Australia, Giovanni met his wife, Stella, who's here with us today, beautiful lady. And there's another picture of the lovebirds. So this union produced two beautiful daughters, Georgia and Elena. Giovanni eventually found himself in Boston, United States. And there's a picture of Giovanni at Boston Children's Hospital with Aldo Castanier and Bill Norwood. And of course, Giovanni, you can recognize him, he's standing behind Bill Norwood. I was in Boston Children's in 1986, and at that time became aware of the Aldo Castaneda Society upon my finishing my fellowship. And talking to Giovanni about the history of the Castaneda Society, there was a dinner with Aldo in 1979, as written by Giovanni, when it was proposed to ARC to form a society. The International Society of Pediatric Cardiovascular Surgery was conceived. The aim was to pursue the goals depicted in the logo of the society, to reach out to the world for the better in pediatric cardiovascular surgery. And you can see on the other side of the World Society logo is the logo of the Aldo Castaneda Society. And here's the list of the presidents of this prestigious society, which kind of preceded the World Society. And you can see Giovanni was a president somewhere in the middle, and Richard Jonas also was a past president, and I had the honor to be the last president of the Castaneda Society. During his stay in Boston, Giovanni spent time with Richard and Stella Van Prague, for whom this named lecture was given by Diane Spicer a couple of days ago. But in order to strive a balance between this school of nomenclature, Giovanni also spent time with Bob Anderson in London in 1988. So the Andersonian School of Nomenclature of Congenital Heart Disease and the Van Pragian School. Giovanni is a leader because under his leadership, an idea that I had had for the centennial of the Montreal Children's Hospital that I shared with Jeff Jacobs, we proposed that we hold a special meeting and reach across the Atlantic. First ever meeting, joint meeting of the Congenital Heart Surgeon Society and the European Congenital Heart Surgeon Association, the presidents of which were Bill Williams of the CHSS and Giovanni Stilling, president of EXA. During this meeting, we had a breakfast of the Castaneda presidents, and we talked about the plan to perhaps convert the Castaneda Society into a world society. Anyways, this was the origin of our organization, at least in conceptual terms. In 2008, with the help of Rob Kinsley and David Horns, the surgeon from from Halifax, whose mom, he's born in South Africa. So between Rob Kinsley and David Horn's mom, we were able to meet Madiba. Giovanni at the time was the first vice president of the World Society, so this was in 2008. In 2010, we organized a special meeting to honor Aldo Castaneda with the participation of more than a dozen international organizations from South America and the rest of the world. At that meeting, we discussed what to do with the Castaneda Society now that there was a World Society. We had a breakfast. Sir Magdi Jakub walked into the breakfast area. I said, Sir Magdi, join us. We're debating to write a proposal, a resolution to dissolve the Castaneda Society. And these were the 7 presidents of the Castaneda Society. And this was the resolution. We proposed the Society of Pediatric Cardiovascular Surgery, Aldo Castaneda, having establishment of the World Society of Pediatric Congenital Heart Surgery be officially dissolved. The symbolic heart of the Castaneda Society will reside from now on within the World Society. So here's Giovanni. He's fearless. He's in constant movement. It's very difficult to track. You have to put a GPS on him. So he loves sports. So there he's on water, on snow, on ground, forcing many of us to run early mornings, jogs. This was in the United States, I believe in Cape Cod at the nomenclature meeting. He's fearless mountain biker. And then he started discovering the motorized mode of transportation. Is this your grandma? She was holding you back. I think she's worried about what's going to happen next. Anyways, from the motorcycle, Giovanni graduated to Cinquecento, I guess, and then discovered the big American cars and went back to the ultimate engine of transportation. Giovanni is fearless. He accepts any challenge. You can see him here panting, catching for air, wondering, do I give up or not? No, he never gives up. There he is on top of the mountain. Giovanni has a special love for Africa. He's done many missions in Eritrea. So these are the 7 lecturers giving the Aldo Castaneda lecture. The first one in Washington by Aldo Castaneda, followed by Roger Me in Australia, Rob Kingsley in Istanbul, Turkey, Konstantin Mavroudis in Brazil, Sir Magdi Yacoub in Abu Dhabi, Bill Norwood in Orlando, and finally, Giovanni still in. Giovanni, it's a great honor for me to introduce you as the 7th lecturer of the Aldo Castaneda lecture at the World Society Scientific Meeting.
Well, it's late, nevertheless, sir. I really would like to say a few words about the organizers. You know, we have to thank and also congratulate Tracy and Bon Zebra and their co-workers and also his family and for the beautiful meeting. And also I would like to congratulate Crystal, Tracy, and Jim St. Louis for putting such a fantastic program together. Some of the slides that I will show to you perhaps were already shown in the European meeting. However, I felt important to address this important message to the African friends and also the non-European people about this giant that has been inspiring our careers. I'll go to the first one. Oh, by the way, some of the slides have already been shown by Crystal, but please forgive me if you see a duplicate. Giovanni still in here. Thank you. Yeah, this is one. Full screen. Can you put the full screen? Yeah, okay. Oh, so an Apollonian surgeon is how Robert Said apostrophized our mentor in his article, paraphrasing the title of Dr. Castaneda memorable presidential address at the American Association of Thoracic Surgery to make a cardiothoracic surgeon an Apollonian quest. Robert Said and Dominique Metras were the first 2 residents to benefit from the great opportunity of training at the Boston Children's Hospital upon Aldo's arrival in 1972. This privilege, however, was subsequently afforded to many of us. As a young pediatric cardiosurgeons, we were drawn to Boston from literally every continent. Aldo Riccardo Castaneda Huberger was born on July 17, 1930 in Italy, Nervi, and now is part of Genova, a charming little town with colorful houses and the romantic marina harbor located in the Italian Riviera between Genova and Portofino. Historically interested enough, let's see if I can get an arrow here. Does arrow work here? No. Interested enough. And there is a Passeggiata Anita Garibaldi in Nervi, which is Anita Garibaldi Promenade, where dedicated to Anita Garibaldi, who was the wife of Giuseppe Garibaldi, who in 1860, with 1,000 soldiers, sailed from Genova all the way down to Sicily to conquer upwards the Italian boot and meet halfway with the Vittorio Emanuele II, which would have become the first king of Italy. Aldo Castaneda spent the first 5 years of his life in Italy, where he attended a pre-elementary school before moving with his family to Munich, where his father studied medicine. During those years, while a teenager, he experienced the horror of Nazis during the World War II, which has profound effect on him throughout his life. He started primary school in Munich, in Bavaria. He completed his academic requirement in Switzerland, where he graduated in 1950, also obtaining at the same time the Oxford certificate. In 1951, Aldo Castaneda moved to Guatemala. While studying medicine at the University of San Carlos, he was at an Italian social club where he met Arceli Ray Rosa, who, like him, has spent several years of youth in Italy and returned back to Guatemala at the end of the war. Aldo and Arceli were married in 1956. Arceli remained at his side as a devoted wife and mother of their 3 children. This is a picture taken at the Aldito's wedding, and you see Aldo Castaneda Jr., Silvana, and Claudia. In addition to being a loving and a devoted partner, Arceli was also a great advisor to Aldo throughout their life together. Much has already been written on how soon after his graduation from medical school in Guatemala, Dr. Castaneda moved to the United States to do experimental work and a new heart and lung machine in the animal laboratory at the University of Minnesota. Due to his remarkable surgical school and his profound interest in research and in teaching, his surgical training was followed by appointments to the faculty of the same university, and he progressed rapidly through academic ranks, being promoted to professor in 1970. In 1972, at the age of 42, the Boston Children's Hospital, after a wild international search, appointed Dr. Castaneda as cardiac surgeon-in-chief and professor of surgery at the Harvard Medical School to replace a pioneer and giant of cardiac surgery, Dr. Robert Gross. And in this picture, you see Aldo was just arrived, and you see Robert Gross holding Aldo's arm with certainly satisfaction and perhaps a little bit of jealousy. I don't know about that. Alexander Nedas, born and educated in Budapest, who was chief of cardiology department in the Boston Children's Hospital, was eager to develop an integrated congenital cardiac program with cardiologists, cardiac surgeons, radiologists, anesthesiologists, cardiac critical care specialists, nurses, and cardiac pathologists, working together in the treatment of children with congenital heart disease. In 1975, Dr. Castaneda was appointed William E. Ladd Professor of Surgery, and in 1981, he became Surgeon-in-Chief at the Boston Children's Hospital. Since that time, his magical collaboration with Alexander Nadas, Richard and Stella Van Prague, Ken Fellows, and soon afterwards with Bill Norwood and many others, proved to be an explosive workshop for developing the modern multidisciplinary approach to management of children with congenital heart disease. The Boston Children's Hospital became the mecca in attracting many pediatric cardiac surgeons for visiting and training from all over the planet. Needless to say that the charismatic young polyglot, Dr. Castaneda, with his sparkling and gentle personality, was inspiring everyone who approached him. He was able to diffuse with great interest his novel treatment for children with a congenital heart disease, fascinating everyone coming from all over the planet. By the end of 1979, many international visitors, mainly from South America and Europe, were populating the Boston Children's Hospital. We frequently met at the cardiac registry, and while sticking our hands in the buckets full of hearts, we were familiarizing with each other in waiting for the Van Prague lectures. We felt all very grateful to their teaching and dedication to us. During that time, Dr. Norwood's pioneering effort in hypoplastic left heart syndrome first survivor, and I was told at that time who was assisting Dr. Norwood with the first survival was Jim Kirkling. The reluctancy from many national and international groups to acknowledge the Boston Children's Hospital progress in early repair of the congenital heart diseases. Edip Jatene effort in switching the arterial vessels. M-mode was available, 2D at the dawn. Cardiac catheterization was a routine tool for diagnosis. PGE1 were not available as yet. Many of the hypoplasts were sending a rush into the operating room before the doctor's closure. With the idea of, by the end of 1979, this slide has been showed already by Crystal, there were several visitors from South America, and Ralph Kuon and myself were resident at the Boston Children's Hospital. And this historical picture has already been shown by Crystal, shows how international was already at that time the Boston Children's Hospital. You can see Dr. Castaneda and Bill Norwood, Steve Van der Venter in between, who became chief in Little Rock, Arkansas afterwards. And on the top left, me with the mustache, and Joe Hatton from Lebanon, and Ralph Kuom from Peru. With the idea of perpetuating our international friendship and exchange knowledge, a few of us launched the idea of establishing a society dedicated to the Boston Children's Hospital and Aldo Castaneda. At dinner that time, we were talking about the society, and Aldo thought of it for a little while, and then he said that, well, for as far as I know, there is no unifying corps at the moment of any class that would gather the pioneer effort of many cardiac surgery in the pediatric fields. The International Society of Pediatric Cardiovascular Surgery was therefore conceived. And this is the beautiful logo, which, by the way, was designed by Ralph Kuhl, who was the first secretary. The first president was Alberto Huffet. The structure of the society was created by Ralph Kuhl. Aldo Castaneda's name was added as a sponsor of this newly created society. The aim were to pursue the goals depicted in the logo of the society, International Society, to reach out to the world for the better in pediatric cardiovascular surgery. These were the precedent that had been already shown by Crystal. And meeting took places every 2 years at the Boston Children's Hospital. And we were very eager to go back to the Boston Children's Hospital. And at the same time, we were looking to go back into the operating room to continue our training at the Boston Children's Hospital. During those years, we were happy of the International Society, which was endorsed by Aldo. We thought, however, that to change a small elite society into a world society of pediatric congenital cardiovascular surgery, there was a need also to remove Aldo's name from the society, as he repeatedly suggested to us, for the sake of its continuity. This is the background which has inspired Christo Chevenkov, when in 2004, he very enthusiastically got in touch with me, proposing of dissolving the Castaneda Society to build a non-elite new society which will encompass the entire world. And this is the first meeting of our society, which has been shown before. We were hosted by Richard Jonas, and this is a picture depicting all the people who attended at the first meeting in Washington, D.C. in 2007. But Aldo Castaneda, before inspiring the whole society, together with other 14 pioneers, pediatric cardiac surgeons in North America, he founded in 1973 the Congenital Heart Surgeon Society, so-called CHSS. In addition, two of the Aldo's European pupils, having had the great opportunity of training at the Boston Children's Hospital, costing on the way from Aldo positive influence on their return to their respective homelands, Germany and Italy, established the European Congenital Heart Surgeon Foundation, which soon became the European Congenital Heart Surgeon Association. Aldo Castaneda has profoundly influenced the career of many cardiac surgeons and cardiologists. His vision of early primary correction of many congenital heart defects in newborn and infant is a crown legacy of his surgical career. The intellectual and organizational substrate that Aldo created in his department led to many important innovations, not only by himself, but also by his younger colleagues. Among the most important to remember are the landmark management of hypoplastic left heart syndrome and the development of the interventional cardiology by Jim Locke. And this is what Jim Locke sent it to me when I was asking to send me something about Aldo. And he says, imagine being 34 years old, pursuing the infant field of interventional cardiology, parachuted into the best cardiac surgery program in the world. Imagine the resentment and the fear of the unknown that settle around us. Success, even more survival, will be impossible without the rarest of the people, a department chair whose only requirement was to do what was the best for the patient. That person was Aldo Castaneda. But a key element of Aldo's legacy is the development of cohesive programs that thrive upon the spirit of collaboration and mutual respect between surgeons, cardiologists, nurses, and related professionals. The rapid progress in neonatal cardiac surgery took place at the same time in which the field of interventional cardiology, pediatric electrophysiology, and pediatric cardiac intensive care were becoming established. Following his outstanding career at the Boston Children's Hospital, Aldo Castaneda was eager to return to Europe and share his new approach to early repair of the congenital heart anomalies, still not totally embraced in the old continent at that time. In 1994, at the age of 64, together with Bill Norwood, Steve Sanders, John Murphy, and other younger cardiac surgeons, he established a new pediatric cardiac surgical program in Genolier in Switzerland. Several years later, he returned to Guatemala, where, with the energy and the enthusiasm of a young man, he built a homegrown center for pediatric cardiac with the aim of providing clinical care for all children with heart disease, a much-needed life-sustaining service which was previously unavailable in this developing country. At the UNICAR in Guatemala City, he created one of the first organized surgical units to treat children with congenital heart defects in Central America. And in addition, he continued to train the next generation of pediatric cardiac surgeons, not only ensuring the future of the unit he had created in Guatemala, but also continuing to inspire and teach young surgeons had created in Guatemala from throughout Latin America and Europe. And this is a slide which shows my pupils, Vladimir Ovida, and next to Aldo Castaneda, who is now replacing me as the chief of pediatric cardiac surgery in Padova, Altin Vesti to the further left, who is now chief of pediatric cardiac surgery in Tirana, Albania, and to the right with the glasses, Mauro Lorito, who is now a consultant in San Donato Milanese, Padova. Milan. Dr. Castaneda will always remain in our memories as the father of the neonatal reparative surgery, having opened an era of primary correction of complex cardiac defects rather than palliation. Most importantly, Aldo inspired all of us to appreciate the importance of surgical education, ethical concern, medical leadership, teamwork, and professional demands. Through his example, we came to appreciate the value of a sincere and honest attitude of self-criticism in any discussion of patient outcomes or any dispute with colleagues. His balanced interest in science and art surgery, in addition to his pursuit of clinical excellence and his deep appreciation from the human side of medicine and science, remain the major motivation factors throughout his outstanding career and always been a guiding light for us. These are Aldo Castaneda and inspire and continue to inspire our medicines. And at the third scientific meeting in Istanbul in 2011, during my presidential address, I was quoting again Article 3 of our Constitution, the vision of the World Society is that every child born anywhere in the world with a congenital heart disease would have access to appropriate medical and surgical care. But how a professional organization like ours should help? I was talking about educational medicines, the strategies for developing new pediatric cardiac programs, model based on long-term and technical support. I was talking about the surgical tourism and medical safari should be avoided and need to develop a matching program for twin programs. I was talking about how a twin program should work alike, Center of Excellence, and the Center of Middle Low-Income Country to be educated. Which is the role of the World Society, I was saying, to establish a relationship of value to both organizations. But how can we achieve this? The World Society can work as a facilitator for building such a coalitions. Well, my friends, while many unimaginable educational goals have already been achieved by our World Society, including our high-class World Journal and the World University and the World Database, and recently our aim of establishing twin clinical programs around the world still need to be launched. Why is that? Background. High-income countries are facing a very low birth rate. For instance, in Italy, it has declined of about 50% on the last 2 or 3 decades. Currently, birth rate in Italy is 7 births every 1,000 inhabitants per year. Well, The mean in Africa is 32 over 1,000, up to 38 over 1,000. In Italy, there are 11 centers for pediatric cardiac surgery to perform no more than 1,500 new operations per year. This has to be thought. Among the several education programs around the world, how many are really educational? How many are simple surgical safaris? Which are the institutions controlling such programs? The fact is, humanitarian missions are still scattered around the world with no global institutional control and or support. In 2017, at the World Congress in Barcelona, I was talking about strategy for successful surgical programs in developing countries. I was quoting our programs to Eritrea, which is a small country with 5 million inhabitants. It was an Italian colony for 60 years, British administration for 10 years, and then for 30 years they struggled for independence. If you go to Asmara, it seems like to go into a movie of the 20 or the 30, you see Cinema in peril. As a matter of fact, there is a big avenue which was called Viale Mussolini. And how our European program started. Hammer Forum is a German group of physicians who are care for children in war and precarious regions of Europe. In 1996, Hammer Forum started a humanitarian project in Eritrea with the goal of building an equipe of professionals to rotate to form at the former Regina Elena Pavilion, now International Operations Center in Asmara, and to commence surgical treatment of children in Asmara on a multidisciplinary basis, including open heart surgery. There were 4 participants: Andreas Urban, former director of pediatric cardiac surgery in St. Augustine, Germany, who was the team coordinator; Bruno Murzi from Italy, Massa Carrara; Pascal Berdard from Zurich, Switzerland, and myself. Objectives of the missions: to correct congenital heart diseases, building a sustained program for children with congenital and rheumatic heart disease, and also training of the local people with the aim of building an autonomous team. Patient management: a 4 team of pediatric cardiologists will screen patients with local cardiologists and select candidates for surgery. Selected patients are further discussed among surgeons, cardiologists, anesthetists before surgery. These are the result in 17 years. We stopped in 2019 because of the COVID. We will probably start at the end of the year. We have performed altogether 1,219 operations, almost half of them with no bypass because there is a very high rate of PDAs. And look at the mortality is compared to the best center in Europe. We have a 2% mortality, including very complex cases like a complex switches operation and other complex things. In conclusion, a conjoined international multi-institutional cardiothoracic team approach is feasible. It could serve as a model for providing a sustained humanitarian pediatric cardiac service in the middle low-income countries. The goal of developing a pediatric cardiac surgical program in Eritrea has been achieved by a European multi-institutional cooperation of 4 different surgical teams. Early and long-term results can be compared with those of the best cardiac surgical units in Europe. However, no independent local cardiac team has yet been established. This has to be meditated. What we have learned: more than one institution needs to be involved for a single educational program. And there is a need for coordinator of the institutional teams, like Andreas Urba did. Each team needs to be supported by his own NGO. And there is a need for a local, well-trained cardiologist. We have a Dr. Zagaredo who is following 1,400 patients and continually. She's an excellent doctor. She was training in Italy as well. There is also very important need for political local support, which can be often cumbersome. There is a need for a basic economical self-sustainability from the country in need. And the need, most important, for a worldwide organization for controlling and sponsoring the educational missions. The World Society can play a very important role. Let's see how. Identify a list of programs to be supported among the World Society members, gathering a list of centers of excellence willing to participate in the educational programs. Most importantly, the World Society needs to seek partnership with the global charitable organizations. World Society, as a global society, must apply for a grant to global charitable organizations like a WHO, Children's Arrow Link, to sustain coalition among educational programs. Center of Excellence, while delivering care to the carrier children in local, but also educate, both in local during the missions, but also with training of the local personnel in their own centers. How to start? The World Society should select centers of excellence and at the same time guarantee the willingness of feasibility of the selected programs to be educated, preferably among an already existing adult cardiac program, which might be easier, even though in Eritrea there was nothing before. Global charitable organizations should explore the political willingness in the country where the program intends to be commenced, like a Minister of Health and other institutional things. How to maintain and develop the program, because one thing is start and the other thing is to maintain. Global charitable organizations should continue to support the established partnership, both economically, politically, and for the maintaining of the local logistics like heart-lung machines, monitors, O2 generators during missions. Close telematic contacts need to be kept among the cardiologists and training cardiac surgeons in local with center of excellence for a continuous clinical support in between missions. Nowadays, this is very easy. In conclusion, which is the main task of the World Society for the third decade of the new millennium? While we, second generation of pediatric cardiac surgeons, had the privilege of having been inspired by the giant pioneers of our discipline, we still need to pursue a closer collaboration among our colleagues in need of education around the world, in closing a still unacceptable gap between the high-income and middle-low-income countries in the effort of unifying the care of children with heart disease around the world. At the moment, the World Society is still the solo institutional scientific aggregation which is devoting all its attention in such an educational strategy in our planet. We members must be proud of it. Let's now move on. Faber quisque, fortuna sua est. Thank you for your attention.
We're quite late, so what time should we reconvene? We're supposed to reconvene at 2 o'clock, but we need a break and lunch. Drissi, are you here? What time should we reconvene? 2:45? What do people think? 2:30? Everybody says 2:30? We're democratic. Yes? 2:30. Let's have a quick lunch and then come back for 2:30.
leaflet, and this is how it looks in the end. You see it's a three-dimensional shape, big, and like we created a new pulmonic valve with a pulmonic valve that works very nicely inside. So this is how we do it once we think that we can preserve the leaflet. Now, this is what happens when we think that we cannot preserve the leaflet. So we start like always, and this is an interesting case because we had to do it twice. You can see that the leaflet looks like it can be preserved, and we can deal with that. This is how it starts. So in the first run, I'm going with the agar. I see that it's small. So agar 7 barely goes. So I decide, like we all do, to go for commissurotomy. Slowly, slowly enlarge all the three. And I think I'm happy with that. And then agar 10 goes easily, and it's almost as needed. So I think, okay, let's finish with it. But when we come off bypass, you see that the right ventricle is 70, left ventricle is 90 thick. So I went back on bypass. We go for the transannular patch like always. You can see now the different, agar 14 goes. But this time, when I look at the leaflets, I have the feeling that they are dysplastic, and they will not function against the monocusp. So we take the measure it again and again, but only when we decide that it's not. What we do, we mark the area where the leaflets are, even though you don't have to do it. We cut them away. And once they are cut, again, we're measuring and creating. And this is the B leaflet way we do it. We're creating a smaller leaflet on the, you can call it the lower side, which actually going to work against the monocusps. And the idea is like what we do in the mitral valve is creating a big zone of cooptation. And this really works because all the cases, again, leave the OR with minimal or no regurgitation or stenosis. Just move a little bit forward. In here soon you can appreciate the wall that this lower leaflet creates when the blood comes back. And against that, the monocusp is going to be created in the same manner like we did in the first surgery. You see how it can stand up in the other direction and of course fall down. And again, we measure the length and also very, very important, the height. And again, it makes a very big leaflet. And we do it the same way. And again, we start in 3 corners. Fix it to its place. You have to pay attention here not to do a press string, not to pull the stitch too hard. Both sides, you see it's creating like a big leaflet, but there is a big cooptation zone between the 2 leaflets. That's why the valve is functioning, and it's functioning for many years. And again, we're creating the top of the main pulmonary artery, making sure that it's high enough. And again, I made a small drawing so you can appreciate the 3-dimensional shape, how it looks in the end. That's a different smile. So that's the second round. That's why we can see the pacemaker wires. And this time, when we came off bypass, see the difference in pressure was completely different. There was no obstruction whatsoever. There was no PI, no PR, no pulmonic stenosis, and we were happy with the results. This is how it looks on echo. You see like there is a new valve, the two leaflets. This is in another view. Thank you.
Much, Dr. Dekel. If there are questions here in I want to ask you about how long this bike lasts on time.
So for our surprise, or not so surprised, this monocasp lasting very long. I even here just have a few pictures. If you would like, I can show you. But even if when in an absent pulmonic valve, there is a child that we've done it when she was 2 months old, and now 10 years after she follow us, the leaflets are there, are functioning. There is small PR, but not more than that. I'm happy to say that because we've been using this system more or less for the last 20 years. Half of the kids are from neighbor countries, so we can follow them. And when we go on missions to African countries, we check the kids that we operated in the past, and none of them have a pulmonic stenosis. And there is some degree of pulmonic regurgitation, but not severe. But with most of the kids, we are able to pass all the childhood period to an adult period, and then of course a valve can be replaced if at all. But they come to this surgery when the right ventricle is preserved, which is very important because there is no PR during their growth and childhood.
Yes.
Giovanni Stellin, I enjoy your technique. However, it is for sure that the best tissue that you can use is the native one, which is by no means that one in the long term will last for a long time. In our experience with the monocasp Gore-Tex augmentation, we had a quite bad experience because after 10, 15 years, the Gore-Tex shrinks and they become calcified and the valve become an incompetence. So looking at your last operation where you remove the cusp or the native valve, I think you should have saved those valves, perhaps doing a delamination or valve augmentation, and I'm sure that the native valve will last much longer than the prosthetic valve. Do you agree with that?
Yes, as you can show that, first of all, half of our patients the pulmonic valve is preserved, and the second half, they are divided. We try as much as we can to leave the native valve in place, and that's what we call the hybrid procedure, monocasp above it. But sometimes we found out that if we leave the native valve, the monocasp doesn't create this cooptation zone, and the patient can leave the OR with mild to moderate PR.
Yeah.
Now, as you can, this is real life. Like we operate on kids who are 3 years old, 4 years old with tetralogy, and the ICU is very smoothly because they are left the OR with no PR. So even post-operative surgery, post-op, the fact that they have no PR once they're leaving the OR, even though they are 3 years old, 4 years old, making the ICU stay a little easier.
I understand that immediate post-operative, though, you have to think in the long term. It is obvious that native tissue will last much better than the prosthetic tissue.
That's
so
true.
I think you should try to preserve your valve as much as you can.
You're absolutely
The valve
right.
that you took it away was a tricuspid, was beautifully preserved if you know how to do it. So I would like to suggest you to try to preserve your valve for as much as possible.
We're trying.
Thank you.
Okay, thank you. I think we can move to the next presentation. It's a tetralogy of valve repair after prior LVOT stenting by Dr. Perry Choi from United States.
Hello. Oh. Hi, everyone. My name is Perry Choi. I'm a second-year cardiothoracic resident at Stanford, and it's my honor to be here to represent our team to talk to you about one video presentation. I think just given the time constraints, I'll play my narrative video, and then at the end, if there's any questions, I'd be more than happy to answer.
Right ventricular outflow tract stenting is a well-established palliation technique for critical pulmonary stenosis, and it is associated with increased pulmonary artery growth, shorter length of stay, and lower PICU admission rates. However, fibrous ingrowth around the stent can complicate future surgical repair, such as close proximity to key structures like the left main coronary artery. In this video, we describe implementation of a triangular baffle to minimize risk to the left main coronary artery during fluid changes. The patient in this video is a 3.7 kilos, 4-month-old male who was born premature at 27 weeks with a birth weight of 600 grams. He presented with tetralogy of Fallot, severe pulmonary stenosis, and no obvious ductus arteriosus. Although the Z-score of the pulmonary annulus was only negative 2.3, significant RVOT muscle bundle hypertrophy caused obstruction, with clinical signs of necrotizing enterocolitis, cyanosis, and sepsis. This prompted several transcatheter interventions, which led to growth and clinical improvement. Through many thoughtful multidisciplinary discussions, we came to the consensus that his operative and postoperative risks were not likely to improve by waiting further, and offered the family surgical repair at this time. Median sternotomy and subtotal thymectomy were performed in the usual fashion. After heparin administration, cardiopulmonary bypass was initiated via ascending aortic arterial cannulation, bicapal venous cannulation, and LV venting of the right upper pulmonary vein. The patient was cooled to 2 degrees Celsius. The main pulmonary artery at the level of the protruding stent was ligated and divided. The branch PAs were dissected out in the bilateral lung hyla. After adequate dissection, a hilum to hilum pulmonary artery homographed patch was anastomosed to the anterior surface of the branch pulmonary arteries, which enlarged the right pulmonary artery to 4.5 millimeters and maintained a 5 to 6 millimeter left pulmonary artery. After cross-clamping the aorta and administering cardioplegia, the right ventricular outflow tract was incised, taking care to avoid conal coronary arteries. This was opened distally through the indwelling stent, and muscle bundles in the RV body were resected. The stent material was clearly very ingrown into the surrounding tissue, and partial explantation was completed. The VSD was then closed using running 6-0 Prolene suture and an autologous pericardial patch. Great care was taken to avoid the aortic and tricuspid valves and placing stitches to the right side of the ventricular crest to avoid the conduction system. At the superior border of the VSD, part of the indwelling stent material was incorporated into the patch suture line. The stent was then further resected off, but the posterior aspect was left intact, as stent material traversed in close proximity to the left main coronary artery and the outer aortic root opposite the right coronary. To avoid risk to the left main coronary artery on future conduit changes, a small triangular piece of autologous pericardium was anastomosed from the posterior aspect of the right ventricular outflow tract incision toward the body of the right ventricle. This maneuver shifted the posterior aspect of the proximal conduit anastomosis anteriorly, away from the coronary. This is shown here, moving the anastomosis from point A to point B. After de-airing the left heart and removing the aortic cross-clamp, the branch PAs were clamped and an incision made along the PA patch for distal anastomosis of the homograph conduit. The homograph conduit was then anastomosed to the reconstructed branch PAs distally. After completion of the distal anastomosis, the conduit was then anastomosed to the right ventricular outflow tract proximally. Again, the posterior aspect of the proximal anastomosis was between the conduit and the triangular pericardial augmentation patch. The anterior portion of the proximal anastomosis was then augmented with a separate hood of autologous pericardium in order to achieve continuity of the right ventricle. Cardiopulmonary bypass was weaned with robust hemodynamics and reassuring BIV function by TEE surveillance. Due to fluctuation of systemic pressures with minimal medical intervention, however, the chest was left open and closed without issues 5 days later. Follow-up echo at 3 months was notable for no stenosis and normal function.
Thank you.
Right ventricular.
That's the end of the video. If anyone has any questions or comments.
Thank you very much, Dr. Choi, for this interesting technique. If there is any question, I think my question is about when do you apply these techniques? Is it for all patients with alveolar stenting or just for some indications?
Yeah, I mean, so our institution actually prefers ductal stenting almost always, and so we rarely do RVO2 stenting. In this case, the patient didn't have a ductus, and that's why we did it. I think in our limited series of RVO2 stenting, this is not a common technique that we use with a triangular baffle. You know, this patient was done pretty recently, so it's still, the jury's still out whether it's going to help avoid injury to the coronary artery in the future. But so far, the kid's doing well, and so we think that it was a successful operation.
Okay. Hi, congratulations, Ignacio from Cordoba, Argentina. So it's a very nice video. I would like if you can comment. We've been doing this for the last 4 years, I guess. If you can comment on your experience, more details, how many patients have done, if all those patients have this patch augmentation to avoid them for the reoperation, and if you can comment on the augmentation of the PAs as well. You can get a deeper comment on the experience.
Yeah. No, thank you, Dr. Hornet. I really enjoyed your presentation yesterday. I unfortunately don't have the exact numbers. Like I was mentioning earlier, we do at our institution prefer ductal stenting. And so I think the number is quite low, especially relative to your institution series. And like I mentioned before, the pericardial baffling is not something that we use routinely. For the PA augmentation, it was actually a little bit borderline in this case. I think the Z-scores of the pulmonary arteries were around 0 for each, but I think in the setting of the kid's clinical scenario was a little bit odd actually. Just had a lot of desaturations from unclear etiology. It was actually started as a pink set earlier on. So I think just in the setting of clinical deterioration, multiple intubations, we wanted to give the right side as much of a chance as we could, which is why we ended up patching.
Thank you for your presentation. I note that this patient had TOF with pulmonary stenosis. So I would tend to argue that placement of a conduit is an overkill for these patients. How about using a translunar patch, using a double barrel technique and trying to give a competent valve using one of the techniques? But then the conduit is going to require replacement anyways.
If I understand the question correctly, you're asking why the valve was not able to be preserved. Is that correct?
Yes. Why a conduit in the first place? Why not a translunar patch and a simple valve reconstruction, or maybe just a translunar patch?
Yeah, and it's a great question. In this case, the RVOT stent, so he had 2 stents, first of all. So the first one, I think, placed around 4 months prior to the ultimate repair. The second one about 3 months. And so I think like Dr. Juaneta mentioned in his presentation, after about 2 or 3 months, it gets very adherent. And so in this case, the valve was completely destroyed, really inaccessible for repair or preservation, sorry. And then why PA conduit? I think that's just our institution's preference. We tend to do homograph PA conduits, RBPA conduits. So that's the best answer I have.
Thank you.
Yeah.
Thank you, Dr. Choi, for your nice presentation. And we move on to the third presentation, surgical management of tetralogy Fallot with absent pulmonary valve, presented by Alexei Subritsky from Russia.
Good afternoon, dear colleagues. It's a pleasure to speak here. And first of all, I want to thank the organizing committee and the hosts of this conference for this great meeting. And my short presentation is dedicated to this lesion, TOF, with absent pulmonary valve syndrome. And in our case, it was also anomalous origin of left pulmonary artery from the aorta. As it was previously mentioned by some speakers, it's relatively rare condition, and the management of dilated pulmonary arteries in these patients range from reduction of arteries through translocation to facing position, and in the most severe cases, sometimes bifurcated pulmonary homograph can be implanted in pulmonic position. So our patient was 2.5 month old girl, 3.5 kilograms, with a history of cyanosis and dyspnea, and failed to thrive, with no history of ventilation. According to CT scans, we can see severely dilated right pulmonary artery up to 2.5 centimeters, with compression of bronchi. So the diameter of left main bronchus is 1.6 millimeters. And you also can see the anomalous origin of left pulmonary artery from aortic arch. So our surgical, considering this anatomy, our surgical plan was corrective surgery with the reduction of right pulmonary artery, reimplantation of left pulmonary artery into the right, and placement of valved conduit in the right outflow. So initially, we can see the dilated pulmonary artery. It's not clear. Okay, severely dilated pulmonary artery. To facilitate a good exposure of this artery, and especially the right hilum, we dissected superior vena cava, fully dissected it, and transected the azygous vein. And here you can see the origin of the left pulmonary artery, which was also fully dissected. After initiation of CPB and after aorta bicaval cannulation, main pulmonary artery was cross-clamped, right pulmonary artery was incised, and I have to mention that care has been taken not to mobilize the posterior wall of the right pulmonary artery. So the anterior wall of pulmonary artery was excised with the reference, with 6 millimeter Heegard dilator as a reference, And also special care was taken to excise lower pulmonary artery wall in the hilum, as far in the hilum as it possible, to eliminate the risk of intrapulmonary obstruction of bronchi. So the next step was oversewing of, here you can see we transect the pulmonary trunk. And the next step was oversewing of the right pulmonary artery with a significant reduction of its size. Yeah, so our main idea was not to mobilize posterior wall due to as it can serve as a it can create a tension which will move anterior wall of trachea and bronchi anterior. So our next step was transection and reimplantation of left pulmonary artery into the right pulmonary artery to create neobifurcation. It was partially anastomosed with the posterior wall of the right pulmonary artery. As you mentioned, these stages are on beating heart. Next step is a distal anastomosis with a 12 millimeter Contigra conduit. And also our aim was to maintain conduit length as short as possible, like to move pulmonary artery anteriorly and out of right hilum. Here you can see transected main pulmonary artery, and there is a narrowed pulmonary annulus without any formed leaflets. So this valve was transected, and after heart was arrested, we closed VSD through the right atrium. And of course, before that, we transect all the obstructive bands in the right outflow. And the last stage was accomplishment of the proximal anastomosis with 12 millimeter Contigra. So this patient had an eventful postoperative course and was weaned from ventilation on POD3. According to ECHO, there were no residual lesions and trivial gradients across RVOT and PA bifurcation, and intraoperative RV-LV ratio was 0.3. So in conclusion, absent pulmonary valve syndrome can be successfully managed by the resection and oversewing of the dilated PAs without posterior wall mobilization. Conduit length should be minimized, and suspension of the PA to the aorta or the sternum can be used in addition to move pulmonary arteries away from trachea and bronchi. Thank you for your attention.
Thank you very much, Dr. Alexis. If there is any question.
I enjoy your video, and I just would like to address you a question. Similar operation that been suggested by 1985 by Roger, me, and myself, and where we're placating the posterior wall and resecting the anterior wall. Now you can get around without, placating the posterior wall. However, what we are suggesting in this article is to pull the pulmonary arteries down. In fact, the symptoms in absent pulmonary valve, with or without a tracheal fallow, are respiratory. So your aim is just pull the pulmonary artery towards the ventricle. I understand that you restrict your conduit. Nevertheless, the pulmonary artery is still against the the bronchi. So I was wondering whether this idea of pulling the pulmonary artery downwards in order to avoid the bronchi, occlusion, it is in our institution and it is included in your video. Do you understand my question? With the conduit, I don't know how much you can pull the pulmonary artery down away from the bronchi.
Yeah. So did you use a conduit in your cases?
No, in this
So-
original article, we
Yeah,
never,
yeah.
there have been several modifications afterwards. However, the concept was that respiratory syndromes should be the first one to be tried to neutralize, and you do that by pulling the pulmonary artery away from the bronchi.
Yeah,
With
yeah.
your procedure, doesn't seem this idea is fulfilled.
Yeah, I absolutely agree with you. So the main concern in these patients are respiratory symptoms, and especially when they have a bronchomalacia. Our aim in this particular case was to implant conduit to minimize the pulsatility of pulmonary
So
arteries.
you put a valve.
Yeah. So the valve was, in our opinion, it was crucial in this patient, and it is recommended too by other groups. So, the next thing, when we want to move it out from bronchi,
Yeah.
we can make aortopexy or sternopexy of this artery too. But in this particular case, after our actions, we revised our surgery, and we saw that pulmonary artery moved out, like medially and anteriorly. Yeah, because we, as I mentioned, we create as short conduit as we could.
Okay.
Yeah.
Thank you. However, congratulations.
Thanks.
Thank you for a very nice video. I was wondering if you have any experience with the bicuspid pulmonary valve described by Dr. Graham Nunn in this position. But that seems to work very well in our experience. That again avoids the use of a conduit. And as far as the taking away the pulmonary arteries from the airways, I have always found that a Lecomte maneuver is a much better adjunct than suspending the pulmonary arteries to the back of the sternum. So achieving a competence of the pulmonary valve by using a Nunn's valve and a Lecomte maneuver to lift off the pulmonary arteries from the tracheobronchitis seems to work very, very nice. But in fact, we had a very large series in the European journal that was published some 10 years back, in which we have detailed our techniques and our experience. So, any experience with the bicuspid pulmonary valve?
Fortunately, we don't have such experience. And I want to say that in this case, we should consider the anomalous origin of the left pulmonary artery, and it was relatively short. And I think in this situation, it would be problematic to move bifurcation anteriorly.
No, that's never a problem. Go down on the ventriculotomy, then your valve can sit upright at the origin of the right pulmonary artery. And to mobilize the P extensively, it's not difficult to lift them up to the entry to the aorta. I think that's very much possible, and our experience seems to suggest that.
Okay, thanks.
I want to know if you compare this technique with the classical technique for tetralogy of Fallot with absent pulmonary valve and its impact really with the on respiratory distress receptor. This comparison.
So unfortunately, I don't know if somebody have enough cases to make such compare. Yeah, fortunately we don't have any possibility because it's quite rare patients.
But you feel that it's better, or there is no?
You mean this technique?
Yeah.
I think in this particular case, it was the best way to manage pulmonary arteries considering anomalous origin of left pulmonary artery. I think it was inevitable to use conduit here.
Thank you, Dr. Alexis. We'll move on to the next presentation, clinical outcomes of tetra GFRO repaired in adulthood, experience from LMIC from Pakistan.
Good afternoon, everyone. My name is Mahi Malik. I'm a congenital cardiac surgeon practicing in Pakistan. I would like to thank the society for giving us the opportunity to present our results. I do have one disclosure that when we submitted our abstract, some of our data was not, hadn't been able to analyze it. So I have additional data to present, which is basically the health-related quality of life outcomes for those same patients. So congenital in Pakistan, tetralogy is a fairly common congenital heart disease. One of the studies from our country showed about almost 25% of patients with congenital heart disease had the diagnosis of tetralogy fellow. Like we've talked about quite extensively over here, that treatment is recommended in infancy. However, a vast majority of our patients do not actually present in infancy. There's well-established higher mortality is possible in those that are left untreated, related to the cyanosis and long-standing hypoxia, leading to RV dysfunction and arrhythmias and other problems. One of the problems that we've been discussing over here also is the challenges faced in developing countries where it's just almost based on our resources, very difficult to perform corrective surgery in infancy and early years. And even though there's data that shows that there's good clinical outcomes after performing repair even in later years, but quality of life has not been very well studied in these patients. I think that most recently, recently there's been more attention on value-based healthcare and looking at patients in a more holistic manner and not just on clinical outcomes. And I think that's where health-related quality of life studies become increasingly important. So the objective of our study was to explore the clinical outcomes of patients who have undergone TOF repair in adulthood, while also analyzing their long-term health-related quality of life. This study was conducted in Karachi at Aga Khan University Hospital. We employed a mixed method study incorporating quantitative and qualitative data. All patients who had undergone primary repair over the age of 18 were included in our study between 2008 and December 2020. We collected quantitative clinical data from chart review, and health-related quality of life data was collected via patient interviews. We did both quantitative as well as a qualitative assessment of quality of life using the SF36 questionnaire, which basically compares 6 domains of the patients to healthy controls. And then we also employed open-ended interviews, which were conducted by members of our research team to really try and identify themes and sub-themes related to their quality of life. At the time of the interviews, we also invited since the interviews were conducted in person, we also invited the patients back to the hospital for an echocardiogram just to collect more clinical data. And this was key because a lot of our patients do not have the resources to travel back and forth. And it was kind of an incentive that we were able to give them that, if you come back and we were going to be doing these interviews, we would also do a full clinical assessment as well. So we analyzed our data, the quantitative data using mean, median, and standard deviation using the SPSS software. We used SF30 scores were used for mean differences. Like I mentioned, the qualitative data was quite extensive, and we had two researchers who collected the data and then analyzed it for themes and then categorized those themes into sub-themes and further categories. So in total, during our study period, there were 66 patients that we identified from our chart review. 10 of those had to be excluded because of various reasons related to inability to collect data adequately. So at the end, we had 56 patients in our clinical quantitative analysis. Out of those 56 patients, we were able to contact 41 of those who were. Out of the 41, 11 could not travel to Karachi to help us to really do the qualitative interviews. So for those, we did the SF over phone, since it's a quantitative and it's fairly easy to administer. So at the end, we had 25 patients who we were able to interview for the qualitative analysis. We reached sample size saturation fairly quickly at about 10, but since we had enough patients who were available for the interview, we decided to include all of them in our study. So this just shows the demographics of our patients. Our median age was of 28 years. The oldest tetralogy patient that we've operated on was 56 years of age. I was not the surgeon for that one. We've had predominantly male patients. We try to gather data for when their age, for the age of diagnosis, and interestingly, at least half of them had been diagnosed at birth or within the first year of life, and for various reasons that we were identify in our qualitative analysis, just had not gotten any surgery. Vast majority of our, well, almost half of our patients were had received primary or less level of education, and the mix from their residents was fairly. So operative details, we employed central aortic bicable cannulation. In this subset, we did not have to, well, all operations were done via transatrial and pulmonary approach. We did not do any through the right, no via through the right ventriculotomy. 21%, so 12 patients in our study sample had previously undergone a BT shunt. These were usually performed at within the first 10 years of life, and that may have been the reason why a lot of these had delay in their primary repair. 46 patients underwent a valve sparing approach. In the rest, 32 had a transannular with or without a monocusp, and 21% patients underwent a bioprosthetic valve placement at the index operation. So our median cross-clamp times was 115 minutes with a bypass time of 150 minutes. Length of hospital stay was relatively longer with a median of 7. Our follow-up ranged from 0 to 126 months. So we had, for some patients, we had a fairly long follow-up. Our median follow-up was 40 months. Post-operatively, all patients presented at least with NYHA class 2 or greater, and post-operatively all patients reported an improvement in the NYHA classification. We did have 4 heart blocks which required a pacemaker placement. There was moderate function in only 1 patient, and the rest had mild to normal function. So in our study sample, the pulmonary regurgitation was severe in 11 patients, moderate in 2 patients. We did, as a part of, and I'm going to this a little bit further on, in the part of our study, when we called the patients back for echocardiograms and interviews, we were able to discover at least 1 patient who had severe pulmonary stenosis that had gone underdiagnosed because he was lost to follow-up, and we were actually able to treat him as a part of our, while we were doing the study. So these are our cardiac reoperations. 2 of our patients, the ones that you can see in the middle with the serial number 3 and 5, patient 3 underwent a re-exploration within the first hospital stay. Patient 5 represented with endocarditis and then had to go back to the operating room for that. And the last one was one of the patients that we saw who had significant pulmonary stenosis and then underwent a pulmonary valve replacement. Pulmonary insufficiency, underwent a pulmonary valve replacement. This is the list of the patients who underwent cardiac catheterizations. 2 of those patients were the ones that I talked about previously. The rest we did have some pulmonary artery stenosis, which were dealt with in the the cath lab. So moving on to our quality of life analysis, these are the domains from the SF36, which was the quantitative aspect. So the way this is that this compares their scores to healthy control subjects, and as you can see on this table, that most patients are fairly close to healthy controls when it comes to self-reported quality of life. Qualitative analysis, and we're able to identify 3 themes. I'm going to go through those 3 themes separately. First theme that we identified was patient perception, and this was related to what they perceived as quality of life and what they, adequate quality of life. And as you can see by their quotes over here, that good health was a primary category that they considered, that if you have good health, then your quality of life is going to be good. The second issue was financiality. These are all, what we have to keep in mind is that these are all adult patients who've had very poor quality of life prior to surgery, and most of them were not contributing, were not financially contributing members of their household. So the financial stability was very important for them. And the positive thing that we identified was that they had pretty strong support from their family and friends, and they felt that because of their family and friends, they were able to live with the disease for as long as they had. The second theme that we identified was just their perceptions before surgery, and what we identified, the most important one was the delay in treatment. And the factors that most frequently came up with, the first was a misconception related to diagnosis and surgery. And we see a lot of this in our community, but just because there's such few pediatric and centers and such few cardiologists and surgeons, that when these patients do present to a primary care physician or a GP, then they're told that their problem is not that bad and they can probably live with it. Some of them were even told that the hole was going to close on its own, and they really didn't have anything, they didn't really need anything. The next most important thing was the fear related to surgery, and a lot of these, because there's such little awareness of the treatments that are available, there was a lot of fear related to getting a surgery, and the fact that, especially when they were younger. And then resource constraints, of course, come up. The loss to follow-up was also very significant, specifically in the ones who had already undergone one procedure, which was a BT shunt, and those were still lost to follow-up, just because they thought, or they had understood, that they'd had one surgery and they really wouldn't need anything else. Next were the symptoms and burdens that they, both physical and emotional, and we just found out that these patients had significant emotional and physical limitations surgery. After surgery, all patients did report an improvement in their quality of life. The physical fitness was a major part, because immediately once you relieve their cyanosis and they recover from the post-operative period, they remove just because of the improvement in their oxygenation, there's a significant improvement in their physical fitness. Of course, emotional and psychological well-being. Now they felt like they had more opportunity to enjoy life like normal people. Actually, quite a few of our patients actually went on to have to regular jobs in college and university and so on and so forth. My banker actually is a post-operative TOF who had his repair when he was 19 years of age. So our study shows that TOF repair can be performed safely in adulthood, although there's a slightly higher risk of reinterventions. And despite late surgical correction, all patients reported an improvement in their functional class. One thing that we did identify was that there's significant risk of loss to follow-up. When we compared this to other that have been published, there's some mixed data out there. So the study from Poland actually showed pretty low quality of life scores in these patients. Ours were better, and one reason for that may have been that our patients had pretty severe physical limitations preoperatively. So anything that's, any improvement was perceived as being better. So in conclusion, TOF repair can be performed safely in adulthood, which I think we all understand well. I think what is important is just looking at patients in a more holistic manner, and not just basing, our studies on what their clinical outcomes are, but also on what their overall quality of life is. And I think this, goes on to just stress the importance of just overall education of patients and families and even community doctors about how important it is to refer patients early. Thank you.
Thank you very much, Dr. Mahanan. We have just the time for one question. Please, no question. Okay.
We call Dr. Murtaza. Dr. Murtaza, is he here? Dr. Murtaza.
So we move to the last presentation by Dr. Obaid Jassim from Dubai. He will present an introductory talk about Nabadat Charity Organization. Sorry? Ah. I don't know. It's cancelled. Cancelled, donc, yeah. Obaid Jassim. Okay. Dr. Obaid is here, but I don't know. Maybe he. During this time, if there is any questions or discussion or any comments about the serial presentation we have this afternoon. Sorry?
My name is Alexandra.
That's fine. Okay. Good. So. Yeah, they told that you're not here, that it's consent. So your presentation is about outcomes of transannular repair of tetralogy follow with contiga monoca split valve, single center experience. Alexandra Wasiak from Poland. Okay, go ahead.
Yes. Good afternoon, ladies and gentlemen. My name is Alexandra Wasiak. I'm a cardiothoracic surgery resident at Children's Memorial Health Institute in Warsaw, Poland. I will be talking about outcomes of transannular repair of tetralogy of Fallot with Contegra monocuspid patch in a single center experience. The surgical repair of tetralogy of Fallot depends on anatomical variations of the heart defect. A group of patients with hypoplastic pulmonary valve annulus need transannular patch. Based on EXA congenital database, it concerns 55.7% of the children. Contegra is an integrated valve conduit derived from a bovine jugular vein, available in a range of sizes and used for reconstruction or replacement of the natural right ventricular outflow tract and replacement of the failed graft. The aim of our study was to evaluate early and late outcomes of tetralogy of Fallot repair with transannular Contegra monocusp patch in the single center. We did a retrospective medical record review. In over 20 years, 224 children underwent tetralogy of Fallot repair with Contegra transannular patch. The primary outcomes were hospital mortality and the need for early reoperations, and the secondary outcomes were late death and event-free survival. 224 patients with 98 girls and 126 boys. The median age at the moment of the surgery was 13 months, median weight 9 kilograms. 11% of children had more complex form of the heart defect. 12 of them had tetralogy of Fallot and complete atrioventricular septal defect. The other defects were aberrant subclavian artery, PA, PVD, left atrial isomerism, AP window, and pentalogy of Cantrell. 58 patients had previous BT shunt. 3 have previous valve-sparing tetralogy of fallow repair, and 10 of them have a previous division of aberrant subclavian artery. We used conduits in 3 sizes, most frequently 20 millimeter conduit. Primary outcomes. The hospital mortality was 3.12%. 7 patients died. The majority of them were the patients with complex form of the heart defect. 2 patients had early reoperations, which is 0.89%. 3 patients were excluded from the study due to no follow-up data available after the surgery. Secondary outcomes refers to the remaining 212 patients. The median follow-up was 116 months, so close to 10 years. The late deaths were 0.47%. 1 patient died because of sudden cardiac arrest at home 6 months after the operation. Event-free survival was 85.4%. 30 patients required reoperation, with the median time to reoperation 99 months. Event-free survival probability was 94.7% 5 years after the surgery and 84.1% 10 years after the surgery. Conclusion: Contegra monocuspid patch can be effectively used in transannular repair of tetralogy of fallow with good long-term results. The complex form of the heart defect increases the risk of the death and the need for reoperation. Thank you for your attention.
Dr. Murtaza. And unfortunately, we have no time for questions, so we move on to the next presentation by Dr. Abeid Jassim about introductory talk about Nabadat Charity Organization.
Okay, good afternoon, ladies and gentlemen. First of all, I would like to thank the organizing committee and the council for giving me this opportunity to talk about our charity in Nabadat. And actually, I have to do it tomorrow, actually, but because we are leaving for a new mission to Mauritania tomorrow, so thanks for the organizing committee to prepone it to today. So the initiative is actually an international initiative. It's a social responsibility program launched by Mohammed bin Rashid Al Maktoum Humanitarian and Charity Establishment. And it's in collaboration with Dubai Health Authority, which is the health authority taking care of healthcare, of course, in the city of Dubai. So in joint collaboration, we have launched this charity establishment to treat congenital heart disease around the world. So His Highness Sheikh Mohammed bin Rashid Al Maktoum, he is a visionary person. He's supporting these type of initiatives. So one of his sentences that if time is life, then it is health that gives time its value, and life its flavor. And he says that together we will provide a decent life for mankind. And we are inspired from his vision and his support. And our vision in Nabadat is to improve the quality of life for children with congenital heart disease.
And our mission is to extend a helping hand to save the lives of children suffering from congenital heart defects in UAE and around the world, and also facilitate the transfer of medical and technical knowledge that will enhance human efficiency in long run. So actually the initiative started in 2007 in October. When I came back from Sweden, we did not have any pediatric cardiac surgery program in UAE, neither in Dubai. So we put this initiative to be a free initiative, free of charge initiatives for people living in UAE. And we called it at that time Initiative to Treat Children with Congenital Heart Disease. And we did it as a workshops with international teams. So I had to invite teams from abroad because the whole team in Dubai Hospital were not exposed to this surgery. So the first team I invited, it was from Sweden, of course, because I was graduated from Sweden and I knew the people there. So we put a program together with them that they come 3 to 4 visits to Dubai and visit for 3 weeks or 4 weeks. And we start treating children with congenital heart disease. And this program, we required at that time from them to come as a large team. We required from them to come as 10 person at least, surgeon, intensivist, anesthetist, nurses, ICU nurses, of course, and perfusionists to teach our team. So, and to build up the services in Dubai Hospital. We did that for 2 years, and then we started collaborating with other international teams from Sweden. After Sweden, we started collaborating with international team from Italy, from America, and also from Saudi Arabia, of course, with Dr. Zuhair Al-Hali's team. And jointly also, we did some missions from with the team from India also. So these are the pictures from our first mission. We did it in Dubai Hospital, the Swedish team. The surgeon at that time, I don't know if you recognize the surgeon, Håkan Berggren. He was working in Sahlgrenska in Gothenburg. And he brought his team. They were 10 people. And within a loop of 2 years, we could reduce the number of people coming to from 10 person to 3 person actually. So because our team start learning and they could run the work with the support of the international team. So when we established this program, people start coming to us from abroad. They hear that we have free surgery. They brought their children and we naturally started accepting them. So these are other pictures from these workshops, what we call it. And during these workshops, of course, we had also teaching sessions for our nurses and doctors. And then also some celebration after the workshop was over. These are pictures when Dr. Zuhair came and visited us, and also when we did missions abroad with him later on. So later on, after we established this service in Dubai Hospital in 2012, when we noticed that a lot of people coming to us and they want to have free surgery, we said that let's go and form an international team and go to these people on their own home country. Because it's a burden for them to come to Dubai, leave their family there and stay in Dubai for a long time. So at that time, we announced the formation of a team under the umbrella of His Highness Sheikh Mohammed Charity Establishment and Dubai Health Authority, and we called it Nabadat, and we gave it a logo. And then we start running missions abroad. The first mission actually was in Sudan in 2012. And then the missions continued in other countries like Ethiopia, like in Tajikistan, also to India, Egypt, Mauritania, so to several countries. We developed some goals for us following the international, actually national and international direction. There are goals to reduce mortality on cardiovascular disease. As you see, there is goals from World Health Organization. They had a goal to reduce cardiovascular death and cardiovascular disease, cancer, chronic lung disease by 25% by 2025. Same as the World Heart Federation also, they had a goal to reduce the cardiovascular disease 25%. So we put targets also to help these organizations nationally and internationally to reduce the burden of cardiovascular disease. And there were other organizations locally also putting same targets. So by time we start developing policies, we start developing standards for such missions. So in the beginning, when we started these missions abroad, we were trying to select some centers or hospitals according to the need. Then by time requests were coming to us, so what we did, we went for a site visit. We have to know the team there. We sit with them. We look to their infrastructure. We look if they have cardiologists, they can do their diagnosis. And then we were sometimes sending people to do small missions, small number of cases with them. After that, we were signing agreement. If the center had a good infrastructure, good manpower, and they were capable to do surgeries, so we were signing agreement with them directly. Otherwise, we were trying to do small missions to test the water, as we say. And then we were doing the preparation. If there are some equipments missing, preparing, buying disposables, sending cardiologists to do the diagnostic echoes in advance and filter the cases and select the patients for cath and surgery. And then we were doing the main missions. When we were doing the main missions, we were taking number of people with us. The number of people was depending on the of the center itself. If they have manpower, can do this type of jobs. Like when we came to Morocco, we didn't need to bring a lot of people. But some other places, we go a team like 30 to 40 people sometimes. So we try to develop a standard for that, and now our aim is our target to stay for 10 days and try to screen 300 to 400 cases in advance and during the mission. And then we try to treat about 100 cases actually. The average number is like 60 cath cases and 40 open heart surgery. And again, it depends on the capability of the team. So it's hard work, morning till evening. And we try, of course, or ensure that the safety is there. Always we aim for the safety. We try to plan our cases together, discuss it in the morning, and of course, select the cases carefully. We put a lot of emphasis and a lot of weight on the ICU after the operations and after the cath lab. We bring a lot of experts in ICU. For example, now we are going to Mauritania. We have 4 ICU doctors, and some of them, they are going to stay after the mission is over to ensure that the last patient is leaving the ICU. We have 10 nurses with us, in addition to the local nurses. So we put a lot of weight on the ICU to make sure that these patients or children are very safe when we leave from there. So these are some showing of some of our results. We have examines for time being more than, or did diagnostic echo for more than 5,700 cases. When it comes to of procedures done, cath and surgeries, more than 1,800 cases. And now we have a data people helping us because you cannot take the same people every time. We do 3 to 5 missions every year, actually. People, they are not free all the time. So that's why we have a database of more than 300 professionals from doctors and nurses. During our missions, also, we try to see if there are lack of some equipments. We take refurbished equipments to them. Also, during our missions, try to implement some teaching so the surgeons can teach the surgeons on the hosting country. Nurses also try to sit with their nurses. Some barriers are there, of course, because the language barrier is the main thing, but we try also to get translators to be with us in these type of missions. And this is a map of showing the countries we've been to and number of cases we have done so far. Again, we try to follow and help to achieve these national and international guidelines and directions. Actually, our authority, they like to also be recognized for this. So they applied for a few awards, and we were awarded for example, International Hospital Federation, that was in 2019 in Oman, for Best Social Responsibility Award. And there was also a recognition in Vienna and Austria in 2018. And we Best International CSR Initiatives in Middle East and Africa. Also, there was also a recognition in Asian Hospital Management Association in Hanoi and Vienna for Community Involvement Award. And locally, there was several awards. I put one of them. It's a program called Our Pride. So I tried to make it short, and this is a video from one of our missions. Actually, I don't know if it will start. So we always thankful for the participants in these type of missions. They come voluntarily from their own time, and we always appreciate their time and their hard work. Actually, it's very hard work because we try to make as many children make use of these missions. So really grateful for these people. And then the support we get from His Highness Charity Office and DHA. They send also an admin team with us, to support us logistically when it comes for ticket bookings, hotel bookings, transportation. You know, there are a lot of requirements. When we have 30, 40 people, they have demands. So we try to make them as comfortable as possible. So last but not least, our logo has a meaning. When we chose this logo, we chose it after deep thinking and some thoughts. So of course, it's a symbol of a heart. That means that we are treating hearts only. Now at this stage, we are only focusing on congenital heart disease, but maybe in the future, we might add adults if it's required. We've been thinking of that. Then we see the lines. The lines are having different lengths, different thickness, and different colors. We didn't mix too many colors, but you can see that different colors. So each thing has a meaning. Different length has meaning that there are different ages we are treating. Different thickness of these lines represent different complexity of the cases, from simple to moderate to high complex cases. And then the different colors represent different ethnicity. So we don't differentiate between from where they come, what color, what religion. We try to treat everybody we can and join them in this program. And by this, I thank you for your attention.
Thank you, Dr. Jassim. And before I close the session, I would like to thank all speakers for the nice presentation and all the attendees. Thank you very much.
Hi, sorry. Hi, everybody. So we need 5 minutes of your attention. Zuhair, come in. So, shall I?
No, no, say whatever you say. You want to give the gifts, the prices first.
Yeah. So the local committee with the organizing committee reviewed the papers and the quality of the work, and we decided to reward the two the best oral presentation. So Christo will tell about the presentation, the oral presentation.
So we had a very rigorous process of evaluating the abstracts. We had 4 teams of 18 to 19 individuals from around the world, each evaluating about 35 abstracts with a number from 1 to 10 based on a number of criteria. And then we put all that information. First of all the abstracts were blinded. There were no names where they come from. So it's as biased as possible. And we put that in the, as unbiased as possible. We put it in, I apologize. We put it in the computer, and it's amazing because the top 2 abstracts had exactly the same score to the 9th decimal point. Top 2 abstracts, just finding here. Okay, so the top abstract is from Santiago, Chile, was presented by Pedro Becker on tetralogy of fall with pulmonary stenosis and early late results of multidisciplinary treatment over 30 years. Pedro, are you here?
Pedro.
Okay. The next abstract had exactly the same score, so it's a tie for first place, by Dr. Maud Radziv, total correction of tetralogy of flow in adult patients, a single center experience from Kuala Lumpur, Malaysia. Is Dr. Radziv here? Is Siva Kumar Sivalingam here?
Yeah.
Siva, come up.
This is a symbolic gift, traditional Moroccan handcraft thing.
And in the absence of Dr. Becker, who is the closest to him? We need somebody from Argentina. Is Ignacio Juaneda here? Well, he's from Chile, but he's not here. So we're going to give his gift to the closest person to his place.
Anyway.
From Argentina?
Colombia. Yeah.
Ignacio. Ignacio Juaneda here, he's the closest. If not, oh, Ignacio, come up. So the tied first prize was won by Pedro Becker from Santiago, but he must be gone, or maybe he's at the pool. So we decided to give you his gift, so you can give it to him because you're close to Chile. So,
well, just before the picture, I think the local organizing committee have voted 2 gifts to the organizing committee. First one goes to Jim St. Louis. And the second goes to our executive director, Christo.
thank you very much.
So here we are. We come to the end of this unforgettable meeting. The workshops on the 15th of June was a big success with more than 20 attendees. The 3 days of our meeting, the discussion was very fruitful and excellent. Both oral and video presentation were excellent. So There were more than between 250 and 300 attendees with more than 42 nationalities, 22 from Africa. My thanks goes to speakers, moderators, and the attendees. Travel a long way. A special thanks to the sponsors, mainly Nabadat, Medware, EM Alliance, and to the organizing company, Habti Voyage, and to the personnel of Kenzie Rose Garden. Thank you.
So at this point, we're going to declare the meeting closed. I know tomorrow there's another symposium on how to start cardiac centers in low and middle income countries. So I invite all of you to attend tomorrow, and following that, there will be the annual or the business meeting of the African Society, during which we will adopt the constitution of the African Society. Immediately following this will be the business meeting of the World Society. So those that are members of the World Society, please stay for that meeting. How should we do it? I think Jeff is going to welcome us to next year's meeting, but do we declare the meeting closed now, or do we do it after Jeff's presentation? Because in a way, we should close the meeting. The meeting it's closed, and then invite the next city to.
Okay, so just to make it clear, there's still symposium tomorrow. So we need to declare the meeting closed now because there is a business meeting afterward. And officially, I declare this meeting closed, and I invite Jeff Jacob to present in the next meeting.
Thank you very much.
Break.
Thank you to everybody who's managed to stay to this late in the day. And Mitch and I are going to show you a little bit of information about our meeting in Washington, D.C. that we've been planning. Again, thank you very much to our hosts in Morocco. This has been an absolutely time for all of us, good science and good fellowship.
The boss is coming.
Did you get that video? All right. Well, Mitch and I are very proud to show you a little bit about what we have planned for Washington, D.C., which is from August 27th through September 1st, 2023. And we hope to be able to create as nice of a meeting as our hosts in Marrakesh have created for us over the past several days. This meeting is both the 8th scientific meeting of the World Society for Pediatric and Congenital Heart Surgery, the 8th World Congress. Amazingly enough, they're both number 8. So as is shown on this slide, the 8th scientific meeting of the World Society for Pediatric and Congenital Heart Surgery will join the 8th World Congress of Pediatric Cardiology and Cardiac Surgery from August through September 1st, 2023. This is the overall logo of the meeting, and there's a little hashtag slogan that people can use to actually access the website and a variety of information. This is the organizing committee. My partner and that's been working with me since 2009 is Gil Wernovsky, and we started putting together the bid to host this meeting in 2009. A lot has changed in the world since that time, but in 2023 we're finally going to put together this meeting. Katie Dodds is the Director of Nursing, Dave Cooper is the Director of Money, and Mitch Cohen, standing to my right, is the Scientific Director, and we'll speak in a minute about some of the components of the scientific track. Despite the pandemic, we have had active planning ongoing week after week, month after month, and we've had meetings either in Washington, D.C. or in St. Petersburg, Florida, really at least every 3 to 4 months for the last several years. This is all of us sitting around the table working on the program this past October, and that's the team that's been doing a lot of this planning. The meeting has 22 scientific tracks, 1,800 talks, 40 cross-disciplinary collaborative sessions, 1,200 invited speakers, 15 abstract sessions. We're planning on an overall attendance of 4,500 people, and the overall budget for the meeting is $4.5 million. At the meeting, we have an international symposium with societies from around the world scheduled for Wednesday afternoon, where all of the different societies from different continents will be hosting their own symposium on Wednesday afternoon. Those international symposium include symposiums from Sociedad Latina that will be presented in Latin. The Pan-Arabic Society will have one, AEPC will have one, and that's going to be around a large number of flags from each country and continent. That's a Wednesday breakout session. We also have something that's called International Village, and International Village is the village that involves global health and charity. And that village is going to have, imagine a village that has 2 hamlets. One hamlet of that village will have global health organizations that are dedicated to charitable heart surgery, and the other hamlet will have parental advocacy organizations. Part of our budget for the World Congress has been to budget in 200 free admissions to World Congress, so free registrations, and 100 free booths in the exhibit hall. And those 100 free booths in the exhibit hall will have 2 people from each of these organizations, probably about 60 from the charitable heart surgical organizations and about 40 from the parental advocacy groups. International Village has a mayor, and the mayor is David Overman over there, and he's leading all of this. And Bistra under David will be managing the global health initiatives, and Brad Marino and Tara Karamlu will be managing the parental advocacy groups. And in August, we'll be sending out invitations to all the organizations. And that will be an opportunity, I think, for a fair amount of collaboration related to a lot of the activities that we're talking about in the meeting. And it's really one of the most important parts of the World Congress for our team. This is a map that shows where speakers are coming from right now. There's speakers from every continent with the exception of Antarctica. My daughter has asked me to find a speaker from Antarctica. So if anybody knows anybody that can come from Antarctica and talk, that would be great. But right now we've got all the continents but Antarctica. These are the 22 tracks. Cardiac surgery is in the top row right in the middle where cardiac surgery should be. And these are all, no offense, Mitch, and these are all the other tracks, general pediatric cardiology.
You realize without electricity, you're absolutely nowhere.
Well, electrophysiology is on here, cardiac surgery, nursing, etc. So these are all the different 22 tracks. The World Society is organizing and leading the surgical tract. So under a program committee that was chaired by Christo and Giovanni and Richard Jonas and James Kirkland, under Jim Kirkland and Giovanni and Christo and Richard, we put together a scientific program for cardiac surgery. And I'll share a little bit about that, and then Mitch is going to talk about a couple of the other tracks. We're not going to go through all 22 tracks, obviously, but Mitch will talk about a couple of the other tracks that are relevant to this group. So again, the surgical program that was organized by those leaders is our scientific meeting. And again, this is all of the different tracks. There's cardiac surgery. The first part about the surgical program is that besides the science, we're going to have all of our usual business meetings held at the World Congress. So the World Congress officially starts on a Sunday morning, but on Saturday evening, we're going to have the meeting of the Governing Council, and that's scheduled for 6 p.m. till 10 p.m. in Washington, D.C. on August 26, 2023. Then on that Sunday, after having science all morning, we have our business meeting, this meeting that comes up. And then on Monday night, we'll have our World Journal of Pediatric and Congenital Heart Surgery editorial board meeting under the leadership of our new editor-in-chief, Carl Backer. This is a snapshot of some of the key components of the surgical track. So imagine every day there's breakfast symposiums. After the breakfast symposiums, the whole Congress comes together in a lecture hall that seats 4,000 people. Within that lecture hall, there's 2 or 3 landmark lectures. And each morning we're going to start by coming together and having these landmark lectures. Some are from surgeons, some from cardiologists, some from anesthesiologists, intensive care doctors, etc. And 2 of those are going to be presented by cardiac surgeons who are major leaders within our own organization. So after that, in the landmark lectures, everybody breaks out into breakout sessions within their own tracks of these 22 tracks. And when our breakout sessions are held, we have a series of surgical breakouts where the World Society has partnered with other continental cardiac surgical organizations to plan each specific breakout. So on Sunday, we have our first 2 breakouts, one about transposition and corrected transposition that's organized by the World Society in collaboration with the Asian Society, one where the World Society collaborates with the Society of Thoracic Surgeons to talk about AV junction. On Monday, there's a couple more. Tetralogy has been done in collaboration with the European Congenital Heart Surgeons Association, and Sociedad Latina has done the left heart obstructive lesions with the World Society. And again, besides those scientific tracks, we have our business that's shown in the kind of purple-pink color here. On Tuesday, there's a session with the CHSS about coronary arterial abnormalities, and then a session with the AATS about cardiac transplantation. There's also a variety of other surgical breakout tracks where we're partnered with basic scientists, where we're partnered with quality improvement experts, and where we're partnered with different subspecialties of cardiology. Wednesday, we have our session with the African Society of Pediatric and Congenital Heart Surgery. That session is chaired by the president of the African Society, Frank Edwin, and we'll discuss in large part a continuation of many of the topics that were discussed here related to global initiatives. And then in the session 8, we have our named lectures and special session where we'll have our presidential address and several of the named lectures. Also on the slide here is a number of other surgical collaborative sessions. Thursday is the abstract competition. And then Friday, we close with the closing ceremonies, which are preceded by plenary sessions on tetralogy and on transposition. And again, I want to emphasize these are the business activities. With that, I'm going to turn this over to Mitch. He's going to take us through some information about the tracks on rheumatic heart disease, which is relevant to this room, nursing, and one of the cardiology tracks. And then I'll close off by showing a little video.
Super, thanks. I think it's equally important to realize as much as World Society of Congenital Heart Surgery is coming into the meeting, there are a number of other meetings that are also going to be embedded into World Congress. So adult congenital, PICS, PCICS, PD rhythm, neoheart, fetal heart. So all of those societies, you're wondering how we're getting to 4,500 people, have agreed to cancel their meeting and also host it. So the interdisciplinary dialogue and discussions that are going to take place are going to be fantastic. So we're going to have, you'll have your meeting, but we'll have surgeons coming in to talk to EP people, and we'll have EP people coming in to talk, and nursing going back and forth in ICU. So we sort of have tried to really build this bridge of dialogue back and forth between to sort of learn from each other. And I think that's an important point to all of this. I'm not going to go through all the sessions. Jeff said we're at 1,800 speakers or talks. We're now at 1,900. It sort of just doesn't really end. There's going to be a lot of stuff on rheumatic heart disease. I know there's been a lot of stuff here, but it's important. This is not just about first world cardiac surgery. This is about first world, third world, developing countries, industrial countries. This is about really the whole composite of congenital heart disease. So there's going to be, Monday, there's going to be a large plenary on great debates in rheumatic heart disease, examining the evidence. There's going to be interactive case discussions. There's going to be emerging science on rheumatic heart disease that Craig Sable and others have been leading. And there's a response to World Health Organizations and a whole global perspectives, a number of debates and everything about how to best deliver care. There's going to be rheumatic heart disease and global health sort of built their sessions together with a lot of overlap. So we tried not, as we build out the program, to have competing sessions so that people can kind of, we want choice, but we don't want so much choice that people are sort of torn where to go. But there's going to be a whole stuff on childhood heart disease, the importance of registries and surveys and databases in developing countries, QI stuff, EKG screening, pulse oximetry screening, and really seamless care across distances. How do we sort of develop care? Christo made some mention about there's 50 some countries in Africa, but there's only 30 some that are even represented here. So how do we engage those other countries to really be part of it? How do we take people from there to bring them to World Congress just to be exposed to this and bring that back to their own country? There's going to be lots of stuff on empowering patients, parents. We're definitely going to have a number of parents and children who've had heart disease speak throughout the sessions. And there's going to be a lot of advocacy, collaboration, a lot of grassroots organizations throughout the thing. Anesthesia is going to be heavily involved. They're canceling their meeting. They're going to be in the program. And there's going to be stuff, NIPQIC, QI, single ventricle programs, all of those things. And also we'll have best abstracts both within global health, rheumatic heart disease, and ambulatory cardiology. Katie Dodds has done a tremendous job building a comprehensive program for nurses. As most people know, I was heavily involved with the Barcelona/Istanbul Certesh. And it was very difficult, I think, in the midst to try to really bring nurses to World Congress. There were financial reasons that made it challenging. I think now that this is going to be in the States, we're hoping to bring a lot more nurses, nurse practitioners, PAs to this program. And there's going to be a huge comprehensive nursing program that has science, that has clinical care, that has QI stuff. And we're really going to try to encourage a huge international participation from within the nursing program. So with that, I think we'll show the video.
Yeah, actually, right before the video, there's a multidisciplinary anatomy lab track that we've set up, and we're doing this in collaboration with Justin Schroeder and many others. And in this multidisciplinary anatomy lab, we're going to have 3D heart models. We're going to have the opportunity for surgeons to operate on 3D heart models mentored by senior surgeons. We're going to have scanning. We're going to have morphologic specimens with Diane Spicer managing morphologic specimens. So while all this is going on, there's also this multi-dimensional anatomy lab.
And just to make a comment about that, a lot of that is going to be, you can kind of come in at your own pace. So you can go to a lecture and then realize I have a 30-minute break and you can walk into the anatomy lab. It's going to have some didactic component to it, but it's definitely going to sort of have a kind of come in, sort of check it out. I have some free time. I'm going to come a little early to the session. So they're trying to create this whole unique format for that.
Yeah, and then for the part where surgeons are operating on the specimens, they'll schedule slots. So there'll be a slot where a surgeon can come in and be mentored by a senior surgeon to perhaps do an arterial switch with a senior surgeon mentoring them, and people will be able to register and sign up for different slots. The pictures on this slide are from the anatomy lab that was held at our meeting, and I can particularly remember going to one table and seeing Richard Jonas helping Jennifer Nelson do a switch on a plastic heart, and there was 25 tables that was what was going on, and we're going to replicate that on somewhat of a larger scale in Washington, D.C. And then the last thing is the abstract competition. So all abstracts are going to be submitted within one of 15 mutually exclusive abstract categories. So most of ours will go in for cardiac surgery. But there's cardiology, electrophysiology, all the different tracks have their own abstract categories. And 135 of these abstracts will be made into oral presentations across the span of the meeting, and the remainder that are suitable will be accepted for posters. We're going to then choose one winner from each oral abstract session who will advance to the championship round, and we'll have a best abstract competition on Thursday, August 31st. So at this best abstract competition, we're going to select the best abstract in the world. And the best one from adult congenital, NICU, surgery, neurodevelopment, basic science, nursing, heart failure, anesthesia, EP, nurse and clinical cath, echo, multimodal, fetal, and general cardiology. All of those will then be presented, and a multidisciplinary panel will choose the top abstract in the world. And with that, what I'm going to try to do is show a little video. This is only the second time we've ever shown this video. Actually, my friend is going to come up and show this video, which is much more likely to be successful.
So the plan is going to be that speaker invites hopefully should go out sometime in October. That's the tentative goals as Gil, Jeff, Coop, and I, and Katie sort of try to get it all done. Abstracts will be open. David Goldberg, many know from running the abstract program at CHOP, has been a really of the abstracts. The abstracts will be sort of an open forum, so there'll be, we'll have an end date for sure, but probably starting in the fall, people can start to submit their abstracts, and then Richard, Giovanni, Christo, Jim Kirkland, since they're the cardiac surgical program, will have all the surgical abstracts, and then they'll send them out to their team to review. And then they'll sort of, we had 1,500 abstract, we had 1,500 posters, if I remember, searches, and I through them in Barcelona. We're expecting to have 2,000 to 2,200 if we start counting all the nursing ones that are likely going to come in. And then I think Dave Goldberg and the team will work with, you come up with your scoring system for where you think those, I think there's a session for 8 oral presentation, 9 oral?
There's 2 surgery abstract sessions, I think, so we may even have more. But right. the key is that the cardiac surgery abstracts will be judged by us, just like Christo described before, with the scoring scale that we choose. The nursing abstracts will be judged, and then we'll choose which ones are oral, which ones are poster, and we'll go on to choose which oral goes into the big competition.
So they'll come in, and everybody who submits an abstract will have to check a box, surgery. So Christo may get some abstract, and it really belongs in the echo bin. It's not really, somebody checks surgery, but it doesn't really belong there. Christo will send it back to us. We'll direct it in the right way. I'm just picking on Christo because I'm looking at him. But that's sort of how it'll go. And then you'll come up with, I think if there's 2 oral sessions, each with 8-minute abstracts, there'll be 16 oral presentations. And then the surgeons, you do not have a competing didactic session when the posters are on. So when the CV surgical posters have their block time, there's nothing else competing that you have to worry about, that's a World Society session. So you guys can all be at the post. How we're going to present the posters, I don't think we
we're still sorting out how we're attempting to create a digital poster platform where we don't have to print posters and they're all digital, and then we have to decide are they vertical or horizontal. Those are details. When we put the bid together, we had a 15-minute video that showed all about Washington, D.C. And what we have today is a 3-minute video where we've taken that 15-minute video, modernized it, and made it suitable for the millennials who like to watch videos on YouTube, who don't have a 15-minute attention span on most days. So this is our new version of our marketing video. On the website, we're going to have the old version too, which is historic for old people like me. So I guess if I hit OK, all right, let's see. So that's our little logo, which is what's on this tie. I usually don't wear very colorful ties, but I wore one today. We're very hopeful all of y'all and all your friends and colleagues will join us in Washington, D.C. next year. And again, thanks to Drissi and the team for a wonderful time here in Morocco. It's been spectacular.
So it will take about 5 minutes to set up the annual members meeting. So the members of the World Society remain.
Lots sales.
You're doing a great job.
I will just
I didn't eat yet.
Lunch?
Lunch.
Or anything? Yeah, I didn't eat. I had so much food last night. I can say.
How was last night?
It was a lot of fun. Yeah, there was lots of music and participation from the audience and lots of food.
Right. There will be no Zoom meeting.
No. Can't wait to.
This is my
Okay, so we're zooming from here to
my
your
account.
Okay, and we do screen share.
So from this.
Okay, so let's start with the agenda file. Have that up on the screen.
There's one page.
Yeah, it's just one page. View, maybe? Is that?
Or mod lecture.
Yeah. Yeah, perfect. Excellent. We can take this up.
There's nothing in what?
Nope, that's it, just 10.
5, 6.
Yep.
Okay.
Okay.
You're welcome.